Hello, I'm Dr. Larry Dorr, and I just want to start by saying what a pleasure it is to be invited to speak to the British Orthopedic Association. That's a real honor, and I'm sorry I couldn't be there, but I really appreciate the opportunity to do this by video. And I'm going to talk today about my research over the last 10 years, which has been predominantly with the use of computers in the operating room and what benefit they can have for us, and then what I've learned about performing the hip replacement operation by using those computers. Okay. I think one of the main lessons I've learned with my research with computers over those last 10 years is that the biggest frontier we have with hip replacement is our human performance. We've got really good materials, we've got great implants. We just need to get to where we can do the operation reproducibly more often for more patients. We all have operated all through these years with manual instrumentation, and that's been our main help besides our own experience and our intuition and our instinct. But the results with that have not been always so great. This is the data that's fairly well known now from Harvard that shows that only 50% of the time was the inclination and the anteversion within the safe zone of Lewinick. So that basically means that they're off by 20 degrees because that's your margin of safety within that safe zone. And if we look at my own data, and this was using manual instrumentation, I had 25% of the implants were outside of 5 degrees of my target number, and I had up to 10% that were outside by 10 degrees, so that I too was not hitting the number as often as I wanted. So that began my use with computerized instruments, and with computerized instruments the instrumentation is the same, and all the computer navigation is, or even robotic use in the operating room is just a high-tech instrumentation. It's instrumentation that instead of manual instrumentation, it's instrumentation that gives you numbers. So on the left-hand column here, you can see that I know my inclination and my anteversion, and though the top two numbers are the anatomic numbers, the bottom two numbers are the functional numbers with the tilt of the pelvis incorporated into the number. And we have here with this CC number, we know our center of rotation. And the ML tells us how medial we are. So we've got quantitative knowledge of what we're doing. And then with that computer use, you can see how my scatter was really contracted. And now I can stay within 5 degrees of my target number all the time. So that obviously improved my human performance. Well, why is this accuracy so important? Well, the fact is that we are doing a biomechanical operation. We're basically doing a mechanical operation in a biological environment, and we have to get the mechanics right. If we don't get the mechanics right, we are going to have complications. They might not be short-term, but they're going to impact the longevity of the operation, and they can impact the comfort for the patient. And we know from our failure studies in the literature, and we know from all of the registry studies right now, that loosening remains the #1 cause of failure, and that the cause for loosening is because of incorrect component placement or leg length and offset. So that the mechanical construction that I've really concentrated on is getting the center of rotation right, and that really is the singular most important technical maneuver we do with hip replacement. And then we have to get the cup position mated correctly to the femoral position. We are operating a joint, so we have to get both sides correctly done. It isn't just the acetabulum, which has had so much emphasis placed on it over these years. But the femur can move 20 degrees into internal rotation when you sit, for instance. And so we have to have them mated together correctly. So what I have learned is the best way to try and accomplish this component positioning is always aim for 40 degrees on inclination, because you have to give yourself at least a 5-degree margin of error. And if you aim for 45, you're going to have cups that are 50 and above. And we know that as soon as we get above 45, we increase wear, and you can increase instability. And as I'll show you shortly, there's a big difference in terms of what happens when you sit down if your cup is 40 degrees versus 50 degrees. And for anaversion, because we have to consider this as a joint, we have to consider both sides. The combined anaversion of the cup and the stem is the best way to think of anaversion and how to determine the anaversion of the cup. And the combined anaversion safe zone should be 25 degrees to 45 degrees. Almost everyone that's worked on the combined anaversion would agree with that. Well, why use combined anaversion? Well, the big reason is most of us are doing cementless femurs in the United States today. It's not as much in England, but it's getting more there, and it's getting more around the world. And the cementless femur does not have the flexibility a cemented femur have. You aren't able to move that femoral stem around. You have to take what you get usually. You've got maybe 5 degrees of flexibility. And the second reason that this is nature's method of stability. This is the way that the body was built. And that data was originally given to us by McKibben, who in 1970 was really interested in how to treat CDH and what the correct hip position was for the human. He worked on infants' cadavers. And he found the average femur was 15 degrees, and the average combined anaversion was 30 to 40 degrees. And if you got down to 25 degrees, you were beginning to have retroversion, and if you were 20 degrees or below, the hip was in frank retroversion, and it just didn't work very well. So let's start with the femur side. Since most of us have concentrated so much in the acetabulum, I had to get good at doing the femur and learning what the femur anaversion was and judging it, estimating it. You can measure it with computer navigation or with robotics, and I've done that. But I've learned that I can get the femur really quite close to within 5 degrees by just estimating it, because you can see the whole leg. It's so much easier to do than the acetabulum. But you can see my learning curve here. It took me about 20 hips to get to where I could be within 5 degrees. So you do have to work at it. If you've got a lot of experience, it doesn't take much longer than this. If you're less experienced, it might be a longer learning curve. But you can get to where you can get your femur close. And as you can see from our data here, that once we get good at estimating the femur and we have numbers for the acetabulum, which we have with computer navigation or with robotic use, I was able to get a correct combined anaversion in 96% of my hips, which means that I've got really good mating of the femur and the cup. Now, the reason that good mating of the femur and the cup is really important is because the cup does change as we go from a standing to a sitting position. And this is data we've really kind of begun to learn about mostly in the last 10 years. I'd say that Lazanek was the one that really brought that to everybody's attention, and we've worked on that also. For instance, if we look at the implants that are the standing position is the AP of the pelvis that you're looking at, and the sitting position is more of the lateral tilt. And if you look at the top row, you see the cup in a standing position, the AP pelvis and the lateral. And then you look at the bottom row and you see what happens when the patient sits. You see the increased inclination that you have. You actually have increased anaversion also. And we've named that anti-inclination because it's anaversion inclination combined. But you can see how much it can change. Well, how much it changes does have a relationship to whether the hip is a stiff hip or a very mobile hip. A stiff hip doesn't change much. The normal change is really about 25 degrees. So in this stiff hip, it changes close to that because the stiffness is minimal, but if you have a really stiff hip, it will change less than 20 degrees. And if you compare that to a flexible hip, and this is the hip that gives us the most trouble even with surgery and post-op with instability, flexible women we know have the highest rate of dislocations. So if you look at a flexible person here, you see on the right where was the standing, and you see the cup's 27 degrees, in that position. This is a lateral sagittal view, so it's the anti-inclination of the cup is 27 degrees. And you see that flexible person sit down, and you see the cup goes to nearly 75 degrees. So imagine if your cup were 50 degrees. It certainly is going to be 80 to 90 degrees. Now you can understand how dropout dislocation occurs. It's not very hard to understand that the hip could drop out if somebody's cup is vertical when they're sitting down, or that it might slide out if they're sitting and they internally rotate to talk to the person next to them. So that's really, I think, the cause of dropout dislocation. There's not so much impingement occurring there. You just drop out because you have such a vertical cup in sitting. Well, with computer navigation, we need to gain the precision, as I started the talk by saying, we need to gain precision in our human performance. And with the computer navigation, we've been able to do this. You can see that we are able to keep our precision within under 5 degrees for both anaversion and for inclination. And the bias is under 1 degree, which means we're really pretty good at hitting our true value, our true number that we're trying to hit. We might not hit it all the time, but if we don't hit it, we're no more than 5 degrees off. And we can look at that compared to the outliers that I already said that I had when I did things manually. You can see with inclination more than 5 degrees, I had 25%, and more than 10 degrees, I had 6. And with anaversion, 29 and 10. So that we've significantly improved my performance with the use of that computer navigation. Well, I wanted to take this to one more level, so I began working with robotic instrumentation. The robotic instrumentation isn't really a lot different than computer instrumentation. It's still just instrumentation. This is the robotic instrumentation made by Mako. And all this does is give us a little more precision and a little more safety factor over what the computer navigation can give us. And the reason we need a little more precision is because if we do manual reaming, even with a computerized instrument, manual reaming still can give us an error of as much as 6.5 millimeters. And that means our center of rotation can be off 6.5 millimeters, superior or medial. Now that significantly changes the cup position and changes the ability of the mating of the femur and the acetabulum to work efficiently for that patient, and it can cause impingement, of course. So to eliminate that error, that human error with reaming, what the robot does is the robot gives us a fail-safe for that error. It stops if you go more than 2 millimeters past your target number. In your preoperative planning, you set up the target number, you set up your target center, and if you go more than 2 millimeters beyond that, the reaming will just stop. So it gives us a fail-safe mechanism for that human performance maneuver. And it does it by creating a virtual tunnel that you're reaming through or that you're putting the cup through or implanting the cup with. And this is the light blue that you see there is the haptic tunnel for the reamer, and if we look at the haptic tunnel for the cup, you see it's much tighter. So you've got a 10-degree margin for the reamer. You're just trying to form a hemisphere so that you've got a little error, a little play there before you make an error, and if you make an error, it'll stop. And with the cup, you have a much tighter tunnel because you want the cup within a 5-degree margin, and actually in our experience, it's always within a 3-degree margin. And so that if this is what it looks like in the operating room, you can see the robot right next to the operating table. That's me holding a reamer. And on the right-hand side, you see what is on the screen at that time. We have the anteversion inclination numbers, but that's not really important during the reaming. What's important during the reaming is the lower 3 numbers on the lower column on the right-hand corner of the screen. And those are the numbers that when we hit those numbers, then we've hit our center of rotation. And the numbers will actually turn green. And if you look at the screen and the acetabulum, you can see that it actually, when it starts turning red, means we've gone past that center. We've gone past it by a millimeter. If we go any further, it'll just stop. The green area on the bottom means that's the area that still needs to be reamed. So the precision of the reaming is quite tight. This is the numbers I was talking about that you see on the screen. The upper numbers are the antiversion and the inclination, and the lower numbers are the numbers on the screen that determine that we've hit our center of rotation in the superior-inferior direction, medial-lateral direction, and the anterior-posterior direction. And then this is the cup being in. You can see I have a mallet in my hand. I'm malleting the cup into position, and the screen tells me that I've hit my position. I have the planned position there, and I have the implanted position. And we are able to keep those within 3 degrees in our experience. And then we also know when we're down because of the lower right-hand corner. The lower right-hand corner on the screen shows how close we are to having the cup fully seated. And you can see that it shows that I'm within 1 millimeter. And if I get within 1 millimeter, I usually stop. Because I use a bone tamp to hit the center of the cup just to be sure I'm down, and that'll certainly give me the last millimeter. So these are the changes that we have with the robot over the computer navigation. Now if we look at our data on the inclination and antiversion with the robot, we can see that we're really not better in terms of inclination and antiversion. We are precise with it. Our bias is good. It's below 1 degree there. And our precision is around 6 or 7 degrees, a degree or 2 more than what we had with the computer. So it's essentially the same. And likewise with antiversion. Our bias is a little higher with antiversion. Antiversion is a little harder to be as accurate with no matter how you do it, manually, computer, or robot. But our precision is still quite good there. And if we look at a scatterogram, we can see that we have very few that are outside 5 degrees, but there are a few outside 5 degrees, so that essentially the robot is no more accurate for inclination or antiversion than I was with the computer. The advantage with the robot over a computer is the center of rotation. And as I said at the beginning of my talk, I really think the most important mechanical restoration and hip replacement is the center of rotation. The center of rotation is so important because if we restore the center of rotation, then you also have a much easier time getting leg length and offset correct. You don't have to use any special devices to do it, and you can do if you can keep the center of rotation with